Okay, we'll start the scenario now. Your time starts now. Um, the same patient, let's continue. So this patient IPS score was found to have obstructive voiding pattern, and patient is quite symptomatic. His IPS score is in the region of 19 with quality of life at 5. And what will be your next steps? You may have heard about this patient. If not, I can summarize you. It's a quite young patient, no medical comorbidities, 49. Examination showed quite large, I mean 60 cc prostate, no neurological findings, no red flag signs. Okay, what is your next steps?
So I will, once he's been assessed, I will discuss the options of medical management, conservative management initially, which my colleague has described earlier. If the patient does not want that or has failed that, I will offer him medical management, and I'll discuss the options of monotherapy with alpha blockers or 5-alpha reductase inhibitors versus combination therapy.
Okay.
His other option is going to be surgical management, but I will give him the trial of conservative management plus medical management first.
Okay, is there any role for urodynamics for this patient? If not, what patients you will prefer to do urodynamics?
So NICE and EAU both do not recommend routine urodynamic studies for patients with LUTS. And this is also supported by the upstream study. Patients who will require urodynamic studies are patients who have had a previous failed surgical management, patients who are young age of 50 or age more than 80, patients who cannot void more than 150 mils, patients who have significant voiding LUTS with a post-void residual of more than 300 mils, or patients with voiding LUTS, significant voiding LUTS with a Qmax of more than 10 mils per second.
Okay, your patient is 48. I'm not sure whether you got the age because you joined
I'm,
late.
I'm very sorry. I will reconsider this, and I will offer him discuss the offering him urodynamic studies.
Okay, good. So, but a good referral, upstream study. It's nice to know that the role is not that much except for very selective patients. Okay, so you are doing urodynamics for this gentleman. What are all the factors or the outcomes or the results you will be focusing on?
So I would like to look at the patient comfort and subtraction, also patient bladder capacity, any detrusor contractions or detrusor activity, patient compliance, um, contraction, capacity, contraction, compliance, and continence.
Okay. Is there any nomograms available for to help you to find whether the patient needs surgery or any intervention?
There is the Abraham Griffiths bladder outlet obstruction index, which the formula of which is P det at Qmax minus 2 Qmax. And if it is more than 40, then this is going to be obstructed. 20 to 40 is equivocal, and less than 20 is non-obstructed. There's also the bladder contractility index, the formula of which is P det at Qmax plus 5 Qmax. And it shows that if the value is more than 150, this means there's strong detrusor contractility. Between 100 and 150 is normal, and less than 100 is weak.
Okay, you will be asked to draw them in the exam. We have tried this whiteboard in the Zoom. It worked okay. You want to give a try? You can draw Abraham Griffiths one. I know it won't be as neat as drawing in a paper, but give a try. Yeah. I think you need to press and draw. Yeah, yeah, press. Yeah, exactly. Yeah, that's it.
Okay, this is not very straight.
That's okay. That's okay. Yeah.
Um, and it's going to be.
So what is in the x-axis? What is in the y-axis?
Mr. Dhanashekharan, I'm sorry, I don't remember.
Okay, don't worry.
Um,
Your
I,
diagram is quite good. and the only thing is you should know what is in the x and y axis. So in the
Yes.
x axis will be Qmax. Qmax will be by ml per second. In the y axis is the pdet at Qmax, and it will
Okay.
be, yeah, since we are measuring the pressure, it will be centimeters of water. And as you know, the Abgram Griffiths number, or to be called as bladder outlet obstruction index, it is pdet Qmax minus 2 Qmax. So that's why the lines are parallel to each other and the lines don't reach zero. You have correctly marked it as just above the zero. So the point where it meets just above the zero, that is 20, and the one above that is 40. So anything in this area, yeah, so anything in this area, you can see my thing possibly, yeah. So anything in this area is obstructed. This is like equivocal and this is like unobstructed. Okay, don't worry, don't stress yourself, that's fine, we got the message. And similarly the changes will be for the next one, bladder contractility index. Do you want to give a try?
So bladder contractility index is like this.
Good.
And this is pdet at Qmax.
Yeah.
And this is Qmax, which is mils per second.
Yeah.
Per second. And this is also going to be mils per second as well. And this is going to be less than, so this is going to be 100. And this is 150.
Okay.
And this is strong contraction, this is normal contraction, this is weak.
Good. So once you know the x and y axis of one parameter, it's both are same. Okay. And y axis pdet by Qmax, pdet into Qmax, and it's a pressure. So the unit is centimeters of water. For Qmax, you know it's ml per second, and your values are correct. It joins at y axis at 100 and 150. So the topmost is strong, then normal, then weak. Good. Well done. And so this patient urodynamically shows presence of obstruction. There is no signs of any other detritus or lack of compliance or anything like that. So what is your next step?
So I will offer him medical management, which I have mentioned earlier. His other options are going to be surgical options. I will give the patient a patient decision aid and bowels information leaflet for the surgical options that are available to him. I can counsel him regarding the medical options, the combination therapy or monotherapy.
Okay. What do you know about the natural history of BPH?
So the natural history of BPH is that as the patient or the man gets older in age, the prostate increases. The Qmax decreases, and I think it was the Garaway study that suggested that BPH of 20 grams plus LUTS or Qmax of less than 15 mils per second with increase of, I think at 40 years of age, there was about 14% of people, between 40 and 49 years of age, 14% of people had this. And at 60 to 69 years of age, about 43% of people had this. So as the men get older, their Qmax decreases.
Okay, any other study explaining the natural history of BPH untreated?
Sorry, I cannot recall it.
Okay, how will you predict that a patient BPH may progress worse? What are all the parameters for you?
So the parameters is from the Olmsted County study that suggests that patients with who have risk of retention are Qmax of less than 12, prostate volume of more than 30 cc, age 70 to 79 years, IPSS score of moderate to severe, PSA of more than 1.4, and post-void residual of more than 50 cc. 50 mils.
Okay, your time is complete now. We can stop now. Okay, good. How do you think you did? I think you did good.
Oh, okay, thank you. I was a bit confused, Mr. Dhanishan, because I wasn't sure if you wanted me to expand further in the medical management, or would you want me to go to surgical management as well?
Not
Because
not
I was really with
necessary.
the M-TOPS and the combat
Yeah.
plus.
Yeah, that's what. So what actually happens in exam is, I mean, today I've sent all four of you the possible scenarios. So sometimes
Hmm.
mentally you may be quite tuned. The first scenario is like evaluation of a patient with LUTS. Second scenario is medical management, but not necessarily that you need to progress. As long as the quality of the discussion is maintained, the examiners will be happy. If you are maintaining quite high quality discussion, you should not be penalized for not progressing, because the ownership is on the examiner to skip some questions, like for example the natural history of BPH progression, everything to take you towards the medical management, to evaluate your knowledge on, as you said, top study and other things. So I don't think you will be penalized for lack of progression, provided the quality of answers are good and there is no wastage of time in between. I don't think you wasted your time anywhere, any time, and your quality is good. Of course the whiteboard is not brilliant, but at least something is there for us to have some revision. And
Yes.
the not getting that x-axis y-axis correctly during the Abraham Griffiths number is fine. It won't really affect the marks to the level of pulling you to the dangerous level. But these are all, as I usually say, these are all absolutely open book exam. So this is the exact question they are going to ask. So make sure that you are absolutely confident on that. And natural history of BPH, you can bring Olmsted County study also. You brought in Garaway study, and but you brought the Armstrong County study later when I asked about the predictors. There are other studies like Ball et al. And Barry, but don't worry about too much, but try to bring as much of studies as possible in BPH and CA prostate table. Otherwise I'm quite happy. There is no major concerns. And regarding the management, it's definitely medical management. He's only 48, no way we can think about surgical management directly. He has to try the behavior management, he has to try the lifestyle changes and medical management, and we should make sure that the medical management is not working before heading towards surgery. And medical management maybe we can discuss in the next scenario, then you will get the overall idea. Okay.
Okay.